and thank you very much for the introduction to come and speak here today too. It's great to get people from different backgrounds together to try and tackle these really difficult problems. I've certainly enjoyed the discussions I've had with people at lunchtime and morning tea. So I'm a pathologist, and I spend about half my week doing cancer research at the Garvan, and the other half of the week trying to put that into practice as a pathologist at Royal Prince Alfred Hospital. So clicker is a bit disruptive, but it was great to hear Michael's presentation, Professor Boyce's presentation from this morning, because in fact I do the testing for Michael's patients for his Lifehouse patients. And this is a case where he sent a sample to us for molecular testing to try and work out what sort of genetic change was present in the tumour of this patient with lung cancer. Now, you don't need to be medically trained to see this tumour here. We can see in the back of the lungs here, we've got this solid mass. It's really quite large. So this patient, we found they did have a mutation in the EGFR gene that Michael was talking about earlier. They received a targeted therapy on the PBS. And in a very short period of time, we click to the next progress, we can see that in only 5 days that this tumour is less than half its original size. So very powerful. I think pictures are really important. That's why people are being shown them today, to really convey the excitement. As has been discussed, many patients do become resistant, but sometimes there are exceptional responders. So the next slide, please. I'm lucky enough to work closely with the group at the Melanoma Institute of Australia, who are really world leaders in their area of melanoma treatment. And this was a patient who had a tumour here in a very, very bad location in the centre of the chest, next to lots of all the large vessels and close to the heart. You wouldn't think this poor patient would have very much time left, given the critical location of that tumour. However, molecular testing was performed, and the patient was found to have a mutation in a gene called BRAF, which is another cancer-linked gene. And this patient received therapy. And if you can click to the next slide, we can see that, again, the tumour has disappeared. It's like spot those different sort of competitions they have. What's amazing in this case is that it's over 2 years between those images. And normally patients with these sort of targeted therapies usually become resistant in about a year. So there are some patients who do very well out of this. So it's critically important to identify these targets for patients in routine clinical practice, and that they can then receive the appropriate therapy. Next slide, please. So I'm pretty sure you've got a really good grip on this concept, probably from your own experience, but certainly from the great talks we've had this morning. And really what we're talking about, particularly with rare cancers, is the need to find that magic bullet, personalised medicine. Now, we've heard quite a lot about the drugs, and we've heard some really exciting possibilities with larger scale genomic testing. But I guess I really want to focus on the sort of testing we are doing right now in day-to-day practice, and where I hope we can go in the very near future to improve options for patients with cancer. So very simply, personalised medicine is the right drug for the right patient. But selecting patients for therapy is absolutely critical because they won't work in patients who don't have the right genetic changes, either something in their own background or more commonly something within the tumour. And this is where the concept of biomarkers come in. And when we're putting into clinical practice, we're basically talking about pathology, the sort of testing that can be done routinely to help guide patient therapy. And you can see in the schema here that really a specific defect is going to be linked to a specific drug, and that will be helpful for that patient, but probably not for others. Next slide, please. So a biomarker is a pretty general term, and certainly in practice there's lots of different ways that we do it. Sometimes it's blood tests, sometimes it's a protein test like here where we actually stain up the cells and look down the microscope. Sometimes we can directly label the genes and identify there are too many copies of that gene within the tumour. So a biomarker is a biological characteristic that's associated with a specific response to therapy, in which case it's predictive, or sometimes for outcome as well, which can be prognostic. And that can be really important, not even for standard therapy, for targeted therapies, but for standard therapy. Which patient needs chemotherapy, which patients may be spared that. Next slide, please. And we've got some really great success stories to look back on and see that it's been worth investing in this area. We've invested enormous amounts of money into breast cancer research, and that has actually paid off. So obviously screening makes a difference, but probably the biggest factor associated with improvement in outcome in breast cancer has been driven by understanding the biology of cancers the molecular defects and then matching that to a therapy. So we've been enormously successful in breast cancer. Over the past 20 to 25 years, the rate of breast cancer death is dropped by almost a quarter in many studies. And a woman diagnosed with breast cancer today has an almost 90% chance of being alive for 5 years compared to about 60% 20 years ago. Incredibly effective and very cost effective has been the use of hormonal therapy in tumours that overexpress estrogen receptors. More recently, Herceptin's been very, very effective, not only in patients with advanced cancer, but when we move it into the early setting, the adjuvant setting, when the patient has just been diagnosed and initially their standard treatment, and then trying to avoid the disease progressing. At that stage, using Herceptin in what used to be the most aggressive type of breast cancer has resulted in half the number of deaths in breast cancer in this group. And really, it's been critical to have in routine pathology practice these biomarkers looking for HER2 gene amplification or estrogen receptor overexpression to enable clinicians to give the patients the right treatment. Next slide, please. And we've heard a lot earlier too about the importance of these driving mutations. And I rather like this visual image of it because there are some cancers that really depend on something pushing them along. And these cancer genes are called oncogenes. And it's said that some of these tumours are addicted to those. So next click, please. So although the more we know about cancer genomes, we understand how complex they are, in some types of cancers, the growth and survival of those cancers can be impaired by just inactivating the product of a single gene. And obviously these cancer genes are very important therapeutic targets. And within our system, publicly funded, there are some great examples. So click, please. Sorry, again. So patients with melanoma, with advanced melanoma, about 30-40% of patients with advanced melanoma will have a mutation in a cancer gene called BRAF, and there is a targeted therapy for that. That's available publicly. Next click, please. We've heard from Michael and others about targeted therapies in lung cancer. Next, please. Very exciting story in a rare subtype of lung cancer, ALK gene rearranged lung cancer, where new therapy crizotinib and Michael Boyce showed the Kaplan-Meier curves showing the difference that makes in that disease. One more, thanks. We've known about Herceptin, trastuzumab for a while in patients with amplification of the HER2 gene, and more recently it's been approved for gastric cancer as well. Next slide, I think you have to click twice. So although the way the MBS and PBS is set up at the moment, it's one test for one drug, but we've had a lot of experience at Royal Prince Alfred Hospital in molecular diagnostics of performing a panel of gene tests on tumour samples to try and help guide treatment for patients. Click, please. So we've now accumulated experience with more than 3,000 patients we've been able to help, routinely doing mutation profiling as part of their standard diagnosis and making decisions about therapy. And we've learned a lot from that experience. Next click, please. So in melanoma, we have found that by doing even a small panel of genes, of 6 genes, we can find mutations that will have an impact on prognosis or treatment decisions for patients in 60% of cases, whereas the standard single gene testing that's currently funded, that most labs do, would have found under half of cases that would have an impact for that patient. We test for additional genes, and so I can think of an example of a gentleman who was found not to carry a BRAF mutation. We found a mutation that's far less common in melanoma. It's only about 1 or 2% of cases in a gene called KIT. There are therapies available for other cancers, and their oncologist was able to access that through various mechanisms. And that patient then had quite a good response for a while because we were able to find that additional mutation. Next click, please. I think it's been really powerful for us in lung cancer, working with a clinical group at Lifehouse who have a number of clinical trials going and very active in research. And again, we're finding over double the number of clinically important mutations in patients with lung cancer compared if we were just doing single gene testing. And again, cases come to mind. As a pathologist, I usually don't get to meet the patients, but the oncologists are generous in sharing the stories. And this particular patient was a man only in his 40s, unlucky enough to have lung cancer, and standard testing had not found a mutation. But we were able to do a panel test and found that although he didn't have a breast cancer or a gastric cancer, he had a mutation in the HER2 gene. And again, through various crafty mechanisms, was able to access therapy, which many patients can't, and had a really good response to that. And we would not even known about it if we'd just done the standard testing up front. So I think we found that testing up front, at least for a small panel, has real benefits. Click, please. It's incredibly useful for triage for clinical trials, and when you're working with leading academic groups like at Lifehouse or the Melanoma Institute of Australia, that means patients get access to therapies they would not otherwise have access to, because up front the clinicians know which trial to send the patient to. We've also learned a lot by following patients who've had this multi-gene testing, and one of the lung cancer fellows at Lifehouse recently reviewed our experience of patients who had detection of a mutation in EGFR and received standard targeted therapy for that. In some patients, we found additional mutations. We didn't know what the significance was at the time. We did report them. And then going back a couple of years later and looking at how patients went, even though they had the mutation that should have meant they would be sensitive and respond well to the drug, if they had an additional mutation in other pathways, then we found that those patients had a much poorer response. So even though we found the one that they should have responded to, knowing the extra information influenced what happened next. And if we were then able to direct patients to different therapies based on the information up front, we could really have a larger impact on how patients go. And then finally, it's incredibly valuable for research. When you're not looking for something, you don't know it's there. If you're only looking within the light, you don't know what's out there in the dark. And by casting a broader net, we're learning things about cancers and how they respond to treatment, how they may be resistant that we'd not otherwise know. And that's a lot of added value. Next slide, please. So the situation in Australia is, and we're actually luckier than many other countries, in that there is publicly funded access for patients, but it's very specific, so specific drugs for very specific indications. So there are 5 tests funded at the minute in solid cancers in 5 cancer types. So EGFR and ALK in lung cancer, RAS for advanced patients with colorectal carcinoma, BRAF in melanoma, and HER2 in breast and more recently gastric cancer. So they tend to be the more common types of cancers. The gastric cancer is less common, certainly. Click next slide, please. So we have been doing routine multi-gene profiling, but it's quite expensive. We've been able to do it because of research grants and philanthropic support, in addition to the Medicare rebate. If we look at, when we think of the cost of the drugs, this is what the tests cost. So the maximum that we can get for doing a lung cancer test is just under $400, and for a melanoma test, it's really only $230. And although costs are coming down at the moment, really it's not economically viable to do routine profiling for that amount of money. So really it's challenging. Click please. So if you're unlucky enough to not have any cancer at all, but one of the common cancers for those specific indications, the testing and certainly the drugs cannot be accessed off-label. So we have seen patients, for example, who have lung cancer and have a mutation in the BRAF gene, which we see more commonly in melanoma. Those patients can't access publicly or outside of a clinical trial or paying for it themselves the melanoma drug, even though there is accumulating data that there is some benefit for those patients. Next click, please. So the profiling that we do is actually not covered under the current system. Next click, please. So I think this really creates inequity then, because it really then goes back to user pays or the laboratories that do the testing absorb the cost. And given the pressures on the budget in public hospitals at the moment, that's simply economically not viable and not possible to do it. So really, unless you're willing to pay, then those patients don't have access to that at all. Next click, please. And for this reason, although we're very lucky in Australia with very high quality pathology services and a lot of really brilliant people working in the area, local labs can only offer the simple single gene testing or very limited gene panels. And often they need to batch the cases together, which can affect how long it takes to get the result. And when you're a patient who's critically ill with cancer and their oncologist trying to treat them, days can make a difference between life and death for patients. Next click, please. So I guess the first part I was concentrating on identifying changes that would allow patients to access smart therapies. But if we even bring it back to even more basic level, as we learn more and more about the makeup of cancers, access to these new technologies, we're really starting to understand that these molecular changes define the tumours and help us make the right diagnosis. So it's become apparent, and it's international standards now, that molecular testing is critical to make the diagnosis, particularly in a number of rare cancers. Click, please. So there's a very rare but often deadly type of tumour called a sarcoma. Affect the soft tissues, the muscles, the fat and the bone. And through the research that's been done, we now know that there are up to 53 different specific molecular changes associated with these different types of very rare cancers to start with. Sarcoma is a very challenging diagnosis to make. I think one of the themes for rare cancers is that patients have a delayed or a misdiagnosis, and that can be certainly the case in sarcoma. I'm lucky enough to work at one of the largest expert centres in the Southern Hemisphere for the treatment and diagnosis of bone and soft tissue tumours. And even my colleagues who are world experts in the area, I see them struggling over cases. And I'm very fortunate that in our centre, through molecular diagnostic oncology, we're able to offer some of these molecular tests to help make the diagnosis better. Click, please. There was a really sobering study that was performed in France where they also have a group that's very interested in sarcoma diagnosis, expert pathologists. And they did a prospective clinical trial where they were given the tissues, looked down the microscope and made the standard diagnosis. And these are experts, very good at what they do. And then they gave a diagnosis, and then they did a molecular test to see if it changed the diagnosis. And in this study, they found almost a quarter of cases there was a change in diagnosis if they had access to the molecular test. Sometimes that was a change as dramatic from a benign to a malignant diagnosis. The little pictures I've got here, this is a rare type of sarcoma of fat called a liposarcoma. If you're lucky enough looking down the microscope, you'll see one of these cells called a lipoblast. They're often very hard to find. But in fact, every cell within this, even the ones that look almost identical to normal fat, will have amplification of a gene change here in MDM2. And if you see that together with a fatty tumour, you can be almost entirely certain this is a liposarcoma and this patient needs more aggressive treatment compared to having a benign fat tumour. But that funding is not, that testing is not funded routinely. Next click, please. So again, unless your local lab is able to somehow squeeze the money out to do that, or pass the charge back onto the patient or the referring doctors, then that critically important information will be missing from your diagnosis. Next click, please. Mark did a great presentation on that really terrible case of that young boy. But I think it's very relevant because brain cancer is an area where molecular diagnosis is essential to make the diagnosis, understand the prognosis, and predict response to therapy. There is a new classification from the World Health Organization for the diagnosis and classification of brain tumours. And although it's been coming for a while, there's been a major shift in that for many types of brain cancer, you cannot make the correct diagnosis without the molecular test. Predictive information about whether patients may respond to really the only available chemotherapy, temozolomide. That testing is not available on the public purse. And then important prognostic information and making the right diagnosis. Again, gene tests are important. And this here is an example of a patient with amplification of EGFR within their brain tumour. This is coming through to other types of cancers, and they do tend to be the rare types of cancers. Patients with lymphoma, the molecular lesion, again, is essential for making the diagnosis in many of these entities, and also for determining whether patients need more aggressive treatment. Some patients with lymphoma have 2 lesions, a so-called double hit, and those patients really need more aggressive therapy. But again, this is not available routinely for patients publicly unless your lab happens to do it or people find the money to do that testing. And I think that's falling behind international standards. And patients with rare cancers, I think, are being disadvantaged. We're seeing this now more and more in rare head and neck cancers and kidney cancers, among others. Technology is moving on, our knowledge is moving on, we're understanding more about these lesions and better ways to diagnose them. Next click, please. Okay, so we've been talking about targeted therapies, and I've just been talking about molecular diagnosis, but as has been alluded to this morning, incredible breakthroughs with a new kid on the block, immuno-oncology. And again, another amazing clinical image from a colleague at Lifehouse, Stephen Cow. And again, you don't need to be a radiologist to see these ones or medically trained. Big mass. the end of December. Next click, please. I think those dates gone wacky, sorry about that. The other way around, go back in time. But anyway, we can see that the tumours disappeared after just 4 cycles of an immunotherapy called nivolumab. Next click, please. But I think immuno-oncology is perhaps one of the biggest challenges we have in terms of selecting patients, which ones are going to respond. It was shown earlier in the presentations from both David and Michael, the amazing responses of some patients. Incredibly, some of those patients, although probably overall about 1 in 5 are going to have responses, some of those patients look like they're having really sustained responses. And it's shown here again too. These are called the swimmer plot. And this line here is where they stop getting treated. Now, some patients don't respond very much, but for a while. But interestingly, there's a group of patients who aren't even on current therapy, but the immuno-oncology approach has woken up their immune system to turn on the cancer, and they continue to respond even if they're not receiving drug. It's pretty exciting stuff for patients with advanced disease. One of the problems is that obviously the drugs are very expensive and they do have side effects, so wouldn't it be great if we could use biomarkers to select patients for therapy? It's very, very challenging at the moment in oncology. I think we're just starting to understand the biomarkers involved, and they're complex. So here is a very inexpensive test that we do every day, hundreds of times in pathology laboratories, called immunohistochemistry. And this is a marker called PD-L1. Click, please. So we've seen there are durable responses in some patients. How do we find them? Next click, please. So what has been found across multiple tumour types is that patients whose tumours tend to have the highest levels of expression of this marker called PD-L1 are more likely to benefit. But there are problems with the test because not all patients who overexpress it respond, and there are patients where the expression is not affected at all, is not linked at all to their response to the drug. So it tends to enrich for patients, so it's good that you can increase the likelihood of responding, but you'd feel pretty cranky if you were excluded from therapy on a test that wasn't very good. Next click, please. Other things that we're realising now too is that the amount of expression can change with time. It can vary from one part of the tumour to another, vary from one metastatic site to another, and can change in time with response to therapy and other factors. At the minute, because all the different drug companies are working to develop their own different test, with multiple different definitions, what they call positive, whether it's any expression, if it's 5%, 50%, and then all different antibodies, different platforms, different cells, we're counting them in, makes it very, very difficult to put that into practice routinely. So to our industry colleagues in the room, I'd really strongly emphasise the need to develop a coordinated, sensible approach to developing biomarkers rather than your own specific one. Try and have a generalised approach that is more robust and can be more easily applied in practice. Click, please. So what is needed to improve options for patients with rare cancers? Click. I hope you've got the clear message that I think we need to fund these molecular tests to ensure patients with the rare cancers are able to at least get a correct diagnosis. Next click. I haven't had a chance to go into this great detail, and maybe Tiffany will cover some of this as well, but I think we need to upskill our routine hospital staff, pathology and scientific, with the skills to perform and interpret testing to move things from research into clinical practice as quickly as possible. Next click. We need support to make sure these new tests are translated into clinical practice, move it from the research institutes as quickly as possible to actually help patients. And maybe one more click. And then to encourage pharma to work together with scientists and pathologists to develop biomarkers that are robust and can be applied in practice. And that's it. Thank you.